I am Dr. Arun Narwekar. I am a consultant physician with special interest in elderly care, attached to Somaiya Super Speciality Hospital, and I am also practicing in this locality for last 30 years. Out of that last 30 years, last 15 years, I have dedicated more to the elderly care, what we commonly call as a geriatric care. India, in my opinion, India is placed at a middle level in elderly care in a global scenario as compared to US, European countries and few Asian countries like Malaysia, Singapore, Taiwan, China. I think we are below them, but we are higher up as compared to African and other Asian countries. We have got the best of expertise in that. So now the focus is more on the geriatric case in India. People are getting interested. There is a social movement about the elderly care, and sooner or later the things are going to improve at much faster speed in India because we have got a pool of talented people as a consultant, nursing staff, occupational therapists, physiotherapists, dedicated counselor, and we in India we have got a culture of charity basically. There are a lot of charitable institutes which come forward to help in a geriatric care basically. And now, since although we think our country is of a young people, at the same time I would say ours is also the country of growing old people, considering the huge population which we have. If you think in terms of the number, yes, we have got a huge population of the elderly people who needs a special attention in a medical field. See, in the rural areas, the elderly care comparatively is much easier because in a rural area there is still a concept of joint families. There are big families where the elderly people are taken care by the family members. There are children, women. Men folks normally they are not stressed so much with the elderly care because they can do their routine activities, go to their fields, jobs. Women and the children they look after that. And normally I personally believe that elderly people or geriatric population, when they are managed at home, they have got a better survival chances, they live better quality of life, they are better looked after. In their cases, the physical injuries are less. Mental trauma of a loneliness which the urban population goes is not there in the rural setup. In urban scenario, what has happened with the collapse of joint family concept, families have become nuclear. There is just husband, wife, elderly parents. Children are burdened with a job pressure where they work from morning 8 till night, midnight. They really don't have time for their parents, although they would love to look after their parents. So in this scenario, the elderly care in the urban setup is not up to the mark, where I think there has to be equal contribution from the society as well basically. Now one concept which I thought in urban areas about the elderly care, like we have crutch for the children, for the women who go to the work, okay, they keep their children in the crutch in the morning, evening they take care. Suppose if there are gated community, big societies where they have a big community hall, society hall, you can have a daycare geriatric center or elderly care center. Morning you keep your parents there, there can be staff of attendant and a nurse, and from that area you can appoint one family physician who can give a dedicated time, maybe an hour or two in the afternoon time, look after their problem. And this concept can work like daycare geriatric centers. Evening when you are back from your work, you can take your parents back. I mean, this is going to be cost effective in the sense keeping attendant at home will cost you minimum 12 to 15,000. Again, the availability of the staff is very poor. They will come for a day or two, third day they will just vanish. In a dedicated daycare center, you will have a dedicated staff which will look after your parents well. The elderly population, what basically they need is a loneliness basically of staying alone in the house. With people of their age, when they are together, there is a social interaction. They share their problems, they share their thoughts, they share their foods. They are no more depressed. At the end of the day, they are happy, and if certain activities can be pursued in these daycare centers, like say music classes, they play some instrument, say storytelling, reading a book, reading a newspaper, I mean, these are small activities, but at the end of the day, these small activities, they play a big role in their mental upkeeping, Ultimately, everybody wants to be happy at the end of the day. Nobody wants to be a loner in their life. Now, unfortunately, in a big cities, the concept of family physician is dying. One reason for that, for a good family physician, the economics is not viable. Now, for family physician, if he has to start a dispensary, he has to buy at least a place which will worth in crores. Okay, and then for 1 crore flat, he has to spend 1 lakh rupees as EMI. Then his recurring cost, how much he is going to basically recover out of that. So that's the reason nowadays you see many of the MBBS doctors, they basically go for super specialty, because once you are MD, MS, okay, you can get attached to any of the hospitals, you can start working there. But family physician, nowadays we are a lot of people who are a BMS, BHMS. Sometimes the government policy doesn't allow them to prescribe the allopathic medicine. That is also coming a big like obstacle in giving medicine. But if family physician with allopathic, Ayurvedic or homeopathic background, they should be encouraged. Okay, so what family physician can do? They can go for home visits. Home visits are required because many times shifting a patient from home to dispensary or a consulting room is basically a big economical burden. Basically, I had discussion with many of my patients. I do a lot of home visits in afternoon time. So they used to tell me, doctor, to bring my parent from home to your consulting, it costs me something around 3,000 rupees. That's the minimum, because the ambulance will charge me 2,000 rupees. Your fees will be there, and time I have to take off from my work. So instead of that, a family physician, he can go home, examine the patient, listen, have a cup of tea, chat with them. Ultimately, what elderly patient they need, they have got basically more of a psychosomatic complaint. There is a complaint for loneliness, they have got aches and pain, few medical problems which can be tackled at a general physician level or primary physician level, which doesn't need a hospitalization or a very fancy investigation. Under National Health Scheme, they are allowed to work till the age of 60, they are paid well, they have got a retirement benefits. Unfortunately, the family care in India, what is given is by basically private general practitioner. None of the government hospital have a primary, like a family physician or a primary care physician. Government hospitals normally they have got either house physician or a resident who work in the hospital premises. They are not allowed to go for a home visits because their working hours are 12 hours, 24 hours sometimes. So government has to decide about family physician as a separate entity. Now nowadays the newer courses they are offering, like degree in a family physician, like in UK or USA, there is a family physician course. Basically, you can specialize in a family physician, where you are taught to deal with the day-to-day emergency at a home level basically. But in India, family physician who MBBS people are not interested really in a family physician, because the salary part is too less. At the end of the 5 years, you spend lakhs of rupees on learning, and then if you are paid by government standard 25,000-30,000, I mean, it is not going to solve your day-to-day problem. So maybe So maybe Ayurvedic doctor or homeopathic doctor, they can be used as a family physician to do home visit, which can be very fruitful in the longer way. This hospital is blessed. Like, we have a medical college with 500 bed capacity, with the best of the teaching faculty. Like, we have got surgery, medicine department, we have got a psychiatry, we have got orthopedic, ENT, whatever the medical college needs, we have got all those faculties are there. We have got a full-fledged diagnostic center, we have got a USG, sonography, CT scan, invasive radiology. There's a good physiotherapy setup, and they have got a physiotherapy school also which attached to the hospital. There's a nursing college. So we have a resource which is almost free from the medical college side. Now, super specialty side, we have a daycare center, we have got rooms which are sharing rooms, twin sharing, we have got super rooms. So, and if you look at the casualty is basically the heart of this institute. The moment patient comes to the casualty, this casualty of Somaiya Hospital is like a ICU. If you see, it's one of the best casualty that I have seen in Bombay. It's almost a 20-bedded casualty with a ventilator, BiPAP machine, there are monitors, there are RMOs which are trained. Most of the RMOs on the casualty, they go rotational training in ICU in this Somaiya Super Speciality for a month. So they are dealing with the emergency, like a patient comes gasping who is breathless, immediately the RMOs they look after in a casualty. Intensivist who is MD intensivist from the second floor, they are called to assess the patient, and then these patients are given a choice. If they can afford, they can be shifted here. If they cannot afford, they can go to the medical college. Geriatric patients, basically when they come to the hospital, they usually come with basically with a fall. Like most of the fall, they got a wrist fracture, they got a hip fractures, or the vertebral fractures. Second commonest thing for they come is the strokes. Basically, they come with a paralysis. Third, many times they came with a delirium. Delirium is basically sudden swing of your intellectual level. Either you are calm or you are agitated, you are hallucinating. This happens many times due to the cause may be entirely different. You can have a pneumonia, you can have a retention of the urine, you can have impacted stools. So these are the three things where geriatric populations come to the hospital for a visit. And sometimes they come for an infection, obvious infection. But in the geriatric population, the problems are never straightforward. The problem which you see, the cause can be entirely different. And once patients are admitted here, we have got the best of facility to offer. We have got a team of physicians, psychiatrists, orthopedic surgeon, plastic surgeon comes in the part when there are bed sores and all that. And the best thing is the mobilization, where the physiotherapists play a major role. A geriatric patient needs to be mobilized very fast. The day the geriatric patient is immobilized, his health starts falling down. There are a lot of physiological changes take place in their body basically. They start losing their muscle mass. The cardiovascular system undergo transformation. Their basic heart rate start increasing. Sometimes there can be fluctuation in their blood pressure. So geriatric patient needs to be mobilized. Like any patient who is in a hospital, he should spend maximum time sitting in a chair if it is allowed. He should have at least 3 walks in the corridor. If you visit the 6th floor of this hospital, I mean, you can play cricket here. We have got so much of a space here, So that allows a long walk even for the patient. There's attached terrace. Okay, you can go to the terrace, sit there, have a cup of tea, look at the horizon, look at the birds, which are the very positive effects basically. See, we want to develop this as a good geriatric center which can offer a quality treatment at a reasonable price. Okay, I wouldn't say affordable cost. See, affordability is a very relative terminology. What you can afford, I cannot afford it. But I would put it as a reasonable cost. Okay, we want to give care which will be much lesser than most of the corporate hospital. Okay, many times we can subsidize the cost by calling a consultant from a medical college where the burden is going to be ultimately less, and our policy is going to be minimum hospitalization, maximum mobilization. So we don't want patient to be in a bedridden for a long period. No, earliest possible we will mobilize, we will try to send him home. Once we get a pool of doctors, we will start think about a process for the home visit in nearby area. Suppose in an area of say 5 kilometers, we can definitely send our nursing staff for some process, like a patient needs to be like Ryle's tube, or there needs to be catheterized, some dressing has to be done, physiotherapy we can arrange at home. One of the doctors, like our resident medical doctors, we can encourage them to go for a home visit at a nominal fee. So this we are going to work it out. Probably by next month, once things are finalized, we'll start our geriatric center or elderly care center.